Morning, everyone. Looks like we have an incredible audience. My name is Dr. Stephanie McNally. I am the Director of OBGYN Services at the Katz Institute for Women's Health. I am also the Vice President of the OB Service Line in Central Region, as well as the Associate Regional Ambulatory Physician Executive in the same space. Thank you so much for joining us for the Katz Institute for Women's Health Mary and Richard Sloan Grand Rounds. At the Katz Institute, our mission is to improve the health of women across their lifespan. With a single focus on women's health, the Katz Institute provides a complete healthcare connection and defines the standards of excellence in patient-centered women's healthcare. Next slide. Aligned with Northwell's mission statement, the Katz Institute is the conveyor, the amplifier of all women's health initiatives, focused on improved health outcomes for women and ultimately leading to a healthier woman, healthier families, and healthier communities. Next slide. We are breaking the mold with our approach to optimizing the health of women, focused on 6 foundational elements. We reinvent the way we practice medicine. We empower women to make informed decisions. We spark the conversation to improve women's health. We prioritize sex and gender-based research, much of which you'll hear about today. We educate future generations of healthcare professionals, and we advance women leaders and promote gender equity. A special thanks to Mary and Richard Sloan for their generous support of this program. The Sloans have been a longtime supporter of Northwell and specifically women's health. Through these grand rounds, we are educating current and future generations of healthcare providers on the latest advances and scientific breakthroughs in the field of women's health. And attendees can receive CME credits for today's grand rounds. Northwell Health is jointly accredited by the ACCME, the ACPE, and the ANCC to provide continuing education for healthcare professionals. At the end of today's program, we will share a link so that you can complete your evaluation and claim your credit. And as a reminder, you only have 48 hours to do so. The following is Northwell's disclosure policy. Northwell Health adheres to the ACCME's standards for integrity and independence in the accredited continuing education. Individuals who are part of this program are requested to disclose financial relationships. All planners and speakers for the program have nothing to disclose. Please submit your questions using the Q&A feature in the webinar. We will have a moderated panel discussion following the presentation. It is now my sheer pleasure and honor to introduce today's speaker, Dr. Elizabeth Cohn. Dr. Cohn is the Vice President of Health Equity Research and the inaugural Iris and Saul Katz Chair of Women's Health Research in the Institute of Health System Science at the Feinstein Institute of Medical Research. She is a distinguished nurse leader and a translational nurse scientist with more than 25 years of experience at North Shore University Hospital and specializes in health equity, precision medicine, and community engaged research. As a clinical specialist in cardiovascular disease, Dr. Cohn has pioneered research methods and models that bring women's health to the forefront of science. Her work has earned numerous honors, including recognition as the White House Champion of Change in Precision Medicine and Health Equity under the Obama administration. She spent 2 years advising the White House Office of Science, Technology, and Policy, ensuring federal programs developed equitable research inclusive of women and minorities. Dr. Cohn is the principal investigator of 2 large NIH Center grants, the Interdisciplinary Guided Network for Investigation, Translational and Equity Ignite for All of Us research program funded by the NIH. She is incredibly thoughtful, intelligent, and it is with great pleasure and an honor to welcome Dr. Cohn to the floor. We're looking forward to your talk, Dr. Cohn.
Oh, thank you so much, Dr. McNally, for that gracious introduction. And thank you all for making time this morning in your morning for this presentation. I'm Dr. Elizabeth Cohen, and as Dr. McNally said, I'm the inaugural Iris and Saul Katz Chair of Women's Health Research at Feinstein. And I'm honored to have the opportunity to celebrate our track record of success in women's health and join Northwell in creating a future of research at the Katz Institute for Women's Health. I just want to say a few words about this picture before I start my talk. The reason that I chose this picture of Marielle is to remind us that we do this work for our daughters and our sons to create a healthier world. Marielle is using her imagination to see better, as we do when we imagine a bright future for research and healthcare. And she is also using it to see further by sitting on the shoulders of her parent, as we do, building on the foundation of those who came before us. We too owe so much to our colleagues who have preceded us and who still surround us, and many of whom are on this call today. Next slide, please. So we really are guided by the vision provided by Iris and Saul Katz, who many years ago saw an urgent need to improve women's health and whose generous philanthropy and guidance has provided unwavering support for the Katz Institute and the researchers and clinicians who have been working towards this vision, many of whom are on this slide, all of whom are on this call today, and there are many, many more. I have to say on a personal note that this isn't just an act of philanthropy, it is also an act of grace and wisdom in helping leave behind a future that is better for women and women's health than we could ever have imagined otherwise. So we are really indebted and grateful to them. Next slide, please. And it's been a decade. It's been a decade of sparking women's health research, over 100 grants, over $1.4 million in funding, hundreds of publications. And this really speaks to the power that the Katzes have had and the Katz Institute has had in lifting up women's health. Next slide, please. So my goal then in returning to Northwell and in thinking about how I can be of service to this already ongoing enterprise, it was to think about a way that we could develop a research agenda that is in parallel with our current outstanding clinical care. And it seemed that it would be supporting the mission and vision of Katz as it stands today, aligning with opportunities for funding and national initiatives, and then leveraging our clinical strength, our expertise, and our reach. Next slide. So just a little bit about women's health and women's health research, because this is an overarching talk about the state of the science of women's health. So across the lifespan, along the bottom of this slide, across the lifespan, from preconception to birth, childhood, adolescence, adulthood, including pregnancy, and then older age, women's health really is at the intersection of biological factors that genuinely make women different, and then social environmental exposures that can change health. So one example, next slide. You can imagine that an older woman, her health very easily could be driven by both biologic factors, things that are happening in your body, and the things that good care and connection to a medical system that prioritizes women's health can impact, but it could also be impacted by economic stability, social and community context. We hear a lot now about people isolating in older age, and that is actually a contributor to their overall health. So we want to think, when we think about women's health broadly, we want to think about all of these sort of factors and how they work together. Next slide. So in addressing this, in thinking about the ways that we can impact it, we want to give thought to how medical research, medical education, and clinical practice have favored men up until this point. So women have been underrepresented in medical research. They have sometimes not been taken seriously in clinical practice, and our medical education often doesn't address the sex and gender differences, something which I'm very aware that Dr. Vinkoff has been working hard to correct. So norms, for example, in clinical practice, norms come from the reference populations are often men, often actually white men. So we want to make sure that things in clinical practice, in medical research, and in medical education balance out or are equitable for women and minorities and others. Next slide, please. So I just want to reiterate, and I know we just saw it, that this effort, this initiative is really in this one is really lifting up our current mission and vision of Katz. We don't want to change the way that Katz is constructed. We want to lift up research, elevate research to match the current mission, vision, and outstanding clinical care that we already offer. So next slide. This just reiterates that this is in service to the current mission and vision, improving health across the lifespan, bridging the gap, educating our community, coordinating our clinical care, and supporting sex and gender specific research. So we are in service to this current mission and vision. Next slide. And then for understanding women's health research, again, just to infuse this with our current definitions, this is about conditions that impact women differently, impact women only, and impact women differentially. And you'll see that, so autoimmune diseases, things like that. So you'll see that in the slide presentation. And then we want to keep in mind, as that model showed us from the Lancet, we want to keep in mind the social, economic, and environmental factors that influence women's health, and address gender disparities in health outcomes in care. And then, of course, it's interdisciplinary, multidisciplinary, and translational across the lifespan. A tall order, no doubt. Next slide. So we wanted to think about ways that we're aligned with opportunities, funding opportunities, and national initiatives. And this too is to elevate the national reputation. Some of the national reputation of institutions is built on the research and peer review literature that institution is putting out. And we really want to make sure that we are on the map at the national level. Next slide. So one of the first things that we did was an inventory of the research that's being done, investigator-developed research that's being done at Northwell. This did not include industry-sponsored trials. This is just investigator-developed research that originated at Northwell. And these word clouds work by thinking about showing how many times a word is mentioned. So the larger the word, the more times it was mentioned in what we saw. So we looked at almost 69 studies being done across Northwell, investigator initiated. And this is how it laid out. And this is a little presentation on its own. It takes about 45 minutes to go through the methodology that we used. But I will say that in this, and I will talk about later on, we can think about whether when designing studies and when initiating studies, especially studies on diseases that disproportionately affect women or have a differential presentation, we can think upfront about how to make sure that we include either an analysis or the mention of women in it so that we can find those studies more easily, because we do run into issues around thinking about what does it mean to do women's health research across all diseases and across the lifespan. So we put a pin in this, and we'll talk about it a little bit later on. Next slide, please. And then we are keeping our eye at the national level on the White House, the Gates Foundation, which we are putting in an application, the Melinda Gates, which we're putting in an application for, the Gates Foundation, which we have in the past put in for and will continue to, the NIH Office of Women's Health, the National Academies, and other funding agencies and philanthropic organizations. Next slide. And then we at Northwell have a really unique opportunity to leverage our clinical strength, our expertise, and our reach. Next slide. So we deliver unbelievable sex and gender, women-centered care. And we do it across all of our sites and in all of our hospitals, throughout all of the Katz practitioners that people have worked to earn that title, and then also to enhance their training through programs like the one that Dr. McNally has in menopause. So we really focus on this, and leveraging our clinical strengths for research at this point gives us a competitive edge because we do it so well. And also it allows us to leverage people's actual passion and work. We don't want to layer another thing to do. No one has time right now to do additional work on top of it. But what we can do is wrap research around the work that we're currently doing so that it elevates everyone. And similarly, next slide, please. Similarly, we want to take advantage of our reach. If we are the biggest healthcare provider in New York State, and that gives us a unique opportunity to lift up women's health in areas both through research and clinical practice that can really raise health. And so our reach can be an advantage. Next slide. And we have then the opportunity to lift up New York in this 2024 Commonwealth Fund state rankings. So we do well. We're in the top 10, but I think something like this can show us an opportunity where this sort of partnered research, this practice-based research, partnered research, can lift up the entire state in terms of our rankings. So we want to leverage our excellent clinical care. We want to wrap research around it and really see New York lead in these ways. Next slide, please. And what would some of those ways what can we do? How can we help? So one thing is clinical trial participation by women. A lot of people at Northwell are interested in this, but not just at Northwell. It's a national issue. It's something that we've been talking about for a long time. In point of fact, it was the impetus behind one of the original Katz grants was a story from Iris Katz on whether we knew enough for women to take aspirin prophylactically. So we want to really focus on making sure that from the beginning of the research all the way through, the research can be applied to and is available for women. So on the left, that purple and teal circle is from clinical trials led by men versus clinical trials led by women out of Stanford, a recent study out of Stanford in 2023. And obviously more clinical trials are led by men, and we'd like to see more of them led by women. And then on the right is a comparison also from cardiovascular clinical trials from the American Journal of Preventive Cardiology, comparing what we need to do to enroll more women versus what we need to do to enroll more minority populations, both of which are important points. But sometimes the strategies there can be different. So at this slide, I want to just take a pause and say that we'd like to make available for people on this call, as you're developing investigator-developed studies, so studies internal to Northwell, where we're writing the IRBs or we're writing the study protocol, a consult service that can take a look way up front to see, is the timing of the trial flexible? Are we designing it so that women can benefit from the research at the end? And there are some specific suggestions about how that might take place. And some of them are to do things, as it says here, to make sure that your inclusion criteria include women, that the timing is flexible. But one of them is to provide education up front prior to even the study beginning about why women should participate in research. And while both of these things are important, and I'm highly committed to both of them, it turns out that some of the strategies differ between the two groups. And so we want to make sure that the studies that we're designing then are applicable to the people who we're trying to reach. Next slide, please. On that note, we are working with the Empire State Development Corp of New York State. Early last month, I facilitated a symposium at the Life Sciences Building with the Empire State Development Corps, who are also interested in thinking about the ways that New York State can support this clinical trial diversity, especially when it comes to the participation of women. So we are really putting great thought into thinking about how this research can be equitable, how we can work towards equality, and the ways at which really coming at it from different angles. So in this particular case, their portfolio includes biotech development, workforce, economic development of New York State. So what does that mean to women's health? And we participated in a similar symposium at the New York Stock Exchange, also in 2024, thinking about what can the New York Stock Exchange do to help women women-owned companies, but women in specific, benefit from clinical research. Next slide. So I'm going to talk a little bit about the All of Us research program, which takes this up at the national level, and then I'm going to bring it home talking about how we might do things here at the state level, at the local level, to improve women's health through research. So a little bit about the All of Us research program. This is a platform that enables research. It doesn't do research on its own. It enables other people to do research. And of course, I'm going to talk about that as a model going forward. Next slide. So we're on our way to 1 million people. This slide is actually outdated. It's 1 million people, and we're at 800,000. So we're getting pretty close. This is a 1 million person longitudinal study, national longitudinal study. It was designed, as Dr. McNally said, it was launched when Obama was the president, as the world's largest and most diverse biomedical data set of its kind. It is reflective. At 1 million people, it's too small to be representative, but it is reflective of the rich diversity of the United States, and it's enriched for populations who have not benefited from research in the past. Next slide, please. So it has about 800,000 participants. 60% of them are women, which is great. That's what we want to overrepresent people who have been underrepresented in the past. It was designed not to repeat past longitudinal studies, but to be a data set that could be newly used to really dig into some of the questions that we have not been able to answer with the data sets that we currently have, which were primarily European ancestry and male. So we have electronic health records, we have biosamples. At the bottom is just a reminder for me to tell you that we already have a data use agreement, whether you work at Northwell or you work at Feinstein. We have an active data use agreement, and after a small amount of training, the data set is available to you without the need for IRB approval. Next slide. And as I was saying, it's about 60% women. And that's intentional. This is an intentional effort to include women and minorities. It's about 60% women, 38-ish% men, and then transgender, non-binary, and did not say. So we are working our way towards more equitable research in efforts like this. Next slide. And this is what it collects. Survey responses, physical measurements, whole genome sequencing, long reads, structural variants, anything that you want is very likely in here, including a full set of medical records. And when we say medical records, we mean all the person's medical records that are in any of the systems, any of the EPIC systems and otherwise. If you enroll at a hospital, you release your hospital medical records, but there's also an option to enroll at Walgreens and through an initiative called Sync for Science, SYNC, Sync for Science, you can sync your own medical records through your cell phone. Next slide, please. And it collects a very extensive set of surveys on the social determinants of health. So we know that about 20% of your health is generated by your access and quality of care. And the other 80% is around socioeconomic factors, the physical environment, and your health behaviors. So we collect everything from neighborhood safety to the environment. We embedded in this is the everyday discrimination scale. So how many times this week did somebody speak to you in a way that indicated that you are not as smart as you actually are? Things like food security, housing, stress, spiritual experience, religious attendance, English proficiency, English as a second language, etc. All of the surveys are available in English and Spanish. Next slide. And I'll highlight some of the work that's currently being done, including my own, where people are thinking about a risk-based approach to breast cancer screening, cardiovascular disease, trajectories of cardiovascular disease risk in sexual and gender minority populations, antidepressant response, which is, of course, a terribly difficult issue to address, and we're grateful for people's work in that area, and the link between discrimination and depressive symptoms. There are other ones too. I reviewed somebody who looked at everyday discrimination and hemoglobin A1C, the relationship there, control of hemoglobin A1C in diabetics. So I think there's a lot that can be really looked at in this data set. And I can talk more about the best ways to use it. Next slide. And then we have diseases that present differently or disproportionately in women. So I'm just showing you here cardiovascular disease for cardiovascular symptoms. And again, you see that we overrepresent women. And similarly with rheumatoid arthritis. So cardiovascular disease might present differently, rheumatoid arthritis disproportionately. But again, we have the opportunity here to look not only between men and women, but also between women and women, which I think might be a more powerful way to look for what could help and would help people in some of these diseases. Next slide, please. And this isn't meant to be read, just to say that for those for those conditions, this is just one deep dive into some of the level of detail that the study allows. And so, including yourself, has anyone had ovarian cancer? If so, when? Endometriosis? If so, when? Fibroids? If so, when? So it really unfolds to greater and greater levels of depth as people answer questions. Next slide. And there's one other option that I think is really important to know, which is that you can join active projects. We ask people to register their projects as they go, and both the data set and the workbench allow us to work across institutions, which has been something that has not been as easy to do as one might imagine. So if you go into the research project directory, you have the opportunity to look and see if people are doing work related to yours, and the workspaces can be accessed by anyone. So we can join a workspace. A Northwell person can join a workspace at Duke, at Columbia, at the City College of New York, at the University of Alabama, Birmingham, and everybody can work in the same workspace together. And we think this is actually one of the most important parts of this is to get institutions working together on a small d democratized data set, free for use and available to everyone. Next slide. And then how do we use it here at Northwell? So I have a grant to use this to address health in the community. And we see all of us as that piece that links our medical system and other medical systems to the work that's being done in the community overall, specifically around community-based organizations. So next slide. This is just a little of our work this is a little of our work this year that we're doing right now. We work with two organizations in New York City, Vision Urbana, which is on the Lower East Side, and the Mexican Coalition, which is in four of the five counties in New York, Queens, Brooklyn, Manhattan. And in the case of the Mexican Coalition, we sat down with the leadership, we geocoded and identified areas that they work in. We presented back to the Mexican Coalition, both in English and Spanish, what we were seeing to get their reaction. This room was completely full, standing room only, and asked them, how can this data be used to really improve health in your community? And the decision there was to enhance an existing community health worker training program to include some of the data that they saw of issues that were affecting the very populations that they were working with. And then our work with Vision Urbana actually helped guide the programming for a wellness center that is embedded in NYCHA housing on the Lower East Side. So that's the type of, we are really trying to provide value, not just the return of value to individuals who participate, but the return of value to the communities, so that they can use the data themselves. And that type of work is how we feel like this data set can really help enhance health. We work across nationally. We are the biostats, the community biostats core for the nation overall. So we work nationally with churches, as you can see here on this list, the ACLU of Alabama, all kinds of maternal health services, the mobile infirmary, to help people really use this data and deliver value back to communities from it. Doing this, we hope, can shift the paradigm of how people think about research and what research might mean to communities who have not been able to take advantage of, or who may have even been harmed by research in the past. Next slide. And a lot of this work is foundational to this book called The Principles of Community Engagement. It is set to come out in 3 days. It is updated every decade. So this is the 3rd edition, 30th year. It is the guidance document for foundational work for the National Institutes of Health, the Centers for Disease Control and Prevention, and Health and Human Services. I had the honor of leading this edition of this book this decade, and it's 200 plus researchers and their community partners. And in it is new models, new methods, metrics, evaluation, dissemination, and implementation for equity. And we are so pleased and proud. This field has evolved dramatically over the last decade, and it was truly an honor to be able to coordinate and facilitate all of these new models and this development of new research. So it's available for free. It's downloadable from the CDC. It's available in English and Spanish. It's designed for download. It's used a lot, of course, in the United States, but it actually has a very wide reach internationally. And so it's downloadable. The chapter, the references, and the tools all download separately. For low resource countries who don't want to download the whole book, each chapter stands alone. So I really encourage you to take a look, and I'll provide a link as soon as it's available. Next slide. And then we have the community grant, and I want to thank my community partners who are on this call. This is a Center of Excellence, P50, in improving health in cardiovascular disease and cancer. It's from the National Institute for Minority Health and Health Disparities, and we find ourselves in very good company with Columbia University, Hunter, ourselves, Feinstein, Pagny, which is the physician affiliate group of New York that staffs health and hospitals, and Weill Cornell Medicine. And I'm going to call out two of our main functions. So this is a center grant. Firstly, next round, available to early stage investigators are $50,000 pilot awards through a Health Equity Scholars Program. So it's a pilot award plus training plus mentorship. It's run by Dr. Daiichi Shambo at Columbia, and that will be available in the next year to early stage investigators who want to develop work around health equity. And then I'll call out the community core, which is called the Connectome, led by Dr. Judy Gomez. Thank you. Who's on this call, and she helps facilitate a number of different initiatives under that, including a linking cab, which links community advisory boards together, a stakeholder meeting, and a set of build awards for community organizations to help them build their capacity to deliver for the communities. And we were on an outstanding call last night till about 9 o'clock. We are extremely dedicated to helping communities helping community organizations. The model here is that community organizations already know what the communities need, and that we can help improve health by helping them build capacity to deliver it. So we'll give you the contact information for any of those activities at the end of the call. Next slide. So how to accelerate research right here at Katz. So a few things that we are doing as laying the groundwork for this. One of them is the Women's Impact Network Registry for Research. So we're calling it WIN for Research. It's bidirectional and multi-directional. And this, again, in the model of all of us, would serve to accelerate everyone's research and be a flexible, living, breathing, buildable data collection source. So it will be expanded to accommodate research questions, data collection, novel analysis to aid clinical innovation and discovery. Next slide. I'm going to talk a little bit about how it works. So it works in a couple of ways. One of them is that we want to start talking to women. As it said on that early slide, we want to start talking to women about why research participation is important. And for that, we want to have a low bar. We want to have a very low level of entry. So just the discussion. We're not signing you up for anything. You don't have to do anything, no extra visits. Just if you'd like to hear more about why women should participate in research and why it matters, we're just going to take name and email and some basic demographics. And what we'd like to do is ask our community, our Northwell community, our Katz community, what research questions are of interest to them. And we'd like to ask you, as our clinician community, what research interests do you have? So what are the research interests of us, of our patients, and of our communities? What type of data is necessary to answer those questions? Where can we get such data? What kind of approach would align with that, especially thinking about women across the life course or hormonal changes? Do we need basic science and qualitative interviews? What do we really need? And then what are the key metrics and variables? Next slide. So women will be able to just scan a code or have a discussion with a clinician or someone in the clinical area, even the nurse at intake or the medical assistant, and just have the ability to receive information about why is this important, and why are we thinking about it now? And so this we have a web page, we have a flyer. We have a set of videos, but the feedback from an initial focus group indicated that that those would be better and more impactful if it was clinicians, people like Dr. McNally, Dr. Rosen, Dr. Vinkoff, myself talking to people on camera about why it was. So we're reconfiguring our videos slightly with the hopes that we can launch this in very early 2024, and we can start getting comfortable. Clinicians can start getting comfortable talking to women about research, and women can start getting comfortable learning about it. Next slide. And ultimately, what we hope is that we can address these heretofore identified death valleys in translational research. So we have known for many years, at least a decade or more, that there's two places where clinical research goes to die. And one of them is the basic research to clinical research, that first death valley. And the second one is clinical research to practice and policy. We have trouble moving our research across into practice and policy, moving our basic science or any research across into clinical research. At last look, it took 17 years. That's way too long for it to benefit anyone. So we propose, next slide. We propose to turn these death valleys into peaks of opportunity. So we're sort of remapping this translational science valleys of death into these peaks of opportunity. And one of them is this model that I'm suggesting, practice-based research. So we want to have practice-based research. We want to generate questions that matter most to clinicians and the patients who they see in the communities that we serve more broadly as Northwell. And then we want to have heightened engagement of women and look at some novel methods that might help us accelerate this so that we're not taking 17 years to put our research into practice. Next slide. So how might we do that? We could reimagine some of the methods that we use. I would contend that comparing women to men every time maybe isn't the right way to go, that maybe we need to think about women-only studies so that we understand what works for what women when, because comparing women to men over and over sometimes doesn't lead us to anything that we can do anything about. So I want to see if maybe redesign, including all women trials, but I have some other ones too. We want to reimagine the way we ask the question, the data that we collect to make sure that we can analyze it appropriately for gender, sex and gender, and then ultimately have successful research that elevates our national reputation and our care. Next slide. So we're working on behind the scenes, we're working on a handbook to follow this. So this isn't slides for you to take home, but just the idea of how this handbook might be constructed. We want to reimagine methods for women. A really great study that that was done actually by Dr. Karina Davidson, who is part of leads the Institute for Health System Science at Feinstein, and who I work underneath, is talked about a study where people had put sensors in their pocketbooks that they used when they commuted to see what environmental exposures people had on their way to and from work, on their way throughout their day. So thinking about digital and wearable technology studies, thinking about passive devices that can passively collect information like that, that people can use for environmental exposure, can help us think about ways where women can participate, because one of the things that we know is that time is of the essence, and we can't have people we can't add another thing to busy women's days. So how can we initiate some of these studies? So digital and wearable devices, environmental exposure studies are one, we heard about it last night again on this call, are one that women are very interested in. Generational and family studies, the effect of the microbiome. So how our microbiome, including gut bacteria and others, are influencing our health. Real world evidence studies. I had about 4 slides like this. I'm only going to show you one, but we have a little handbook that outlines the description, the pros, the cons, and then how it might be incorporated into your research. Next slide. Take one of these apart. I'm just going to take it apart a little bit. So I talked a little bit about studies, what impact do environmental exposures have on women's health, and ways that we might collect that passively so that we can help women understand what they're being exposed to and when. There's a lot of work around hormonal changes, a lot of thoughts about the work around hormonal changes, not as much as we would like to see more work on it, actually figuring out when and how to measure this. Like, what's the best measure? When should we measure it? How should we measure it? And what kind of studies can we design that would help us better understand it? It was an exclusion criteria for many, many years. So now that we'd like to make it an inclusion criteria, how would we do that? Mental health issues, I'd like to look at the role that sex and gender play, obviously, and then digital tools. Next slide. I just will show you one of these to sort of say, how would we build it? So if we use the environmental exposure one at the top, what data do we need to collect? Do we have it already? Is there a source for that already, or should it be added to the WIN registry? Next slide. And then if we add it to the WIN registry, what should we do research approach-wise? How will we need to analyze it? And then what are the key metrics and variables that we can pull from it? I won't go through all of these, but you could see how we can build a research agenda around these very specific issues. Next slide. Just a quick shout out to Dr. Sandeep Kapoor. We just put in a grant yesterday together, and I just want to say that he is with the Firearm Group. He is doing an Empowering Conversation Summit on substance abuse and women's health this Thursday. Don't miss it. He's fantastic, and I think this type of cross collaboration across Northwell is really important and really lifts all of us up, both in research and in health. Next slide. So in wrapping up then, we are in concert with the Women's Health Alignment Structure, so the Women's Impact Registry. We just put in a grant to the CDC on firearm injury prevention in OBGYN clinics with Drs. McNally, Vinkoff, Chethan, and Dr. Kapoor. It's a really nice grant. I really hope we get it. It's a fabulous opportunity for us to leverage some of the strength of our system already and think about ways that we can build women's health around it. I had a very active role in Vote North and the Center Corporate Social Responsibility, and thinking about the effect that policy has on the health of women, on women's health cancer. We're working with, of course, my own grants, Ignite and Community. We're thinking about a collaboration with the Emergency Medicine Department. We just did an event at Mother AME Church in Harlem, talking to women about research participation in mental health. And then lastly, I was honored this year with the Blue Cross Blue Shield Whole Health Hero, which allowed me to help warm up with the Mets, which was really a great honor and great fun. Next slide. So thank you for your time this morning. In our future state, we are thinking about the Women's Impact Network Registry as a platform for accelerating our oral research overall. We are putting a health lens, a women's health lens, to research in progress. And I'll add that we'd like to launch a consultation service to consider an analysis that supports women's health when people are designing their studies. You can join us, join up, join in, nominate your practice to enroll women in WIN and your data for inclusion. And ultimately, we'd like to lead the nation in women's health research, and we are on our way to doing that. And again, I just want to thank the Katzes for their support and the Katz Institute for Women's Health for the opportunity to share my work this morning. And with that, I will take questions.
I mean, that is incredible. And being able to work with you closely and even hear it from that high level to the granular just is incredibly inspiring. So thank you for all that you do. A couple of questions, and I'm sure that things will come in through the Q&A as well. One person had mentioned, yes, it is early 2025. We are way ahead of it, putting all the pieces together. So in terms, Dr. Cohn, when we're looking at starting these consult services, which I think is great to have your expertise to really help us guide moving forward, what do you think is the best way to really get in contact with you, and what should we be prepared in that consultative process? What should we come with?
So thank you for that. And first, my email, I'm going to put my email in the chat. Maybe I'll ask actually somebody to do that, because when I clicked in the chat, we blanked the screen, but I'll put my email in the chat by the end of the call. I think that what we have found, having done a number of these types of consultation services, is that designing the study up front, and this is also what we found when we looked at the 69 studies being done. So one way is if it's a disease that affects women, like your work, Steph, the menopause work, that one's pretty clear. But if you're doing a cardiovascular disease study, it's worth it upfront to think about, is there an analysis plan on the back end that can help us make sure that we capture sex and gender differences? And in order to capture sex and gender differences at the end, we have to design for it in the beginning. We have to make sure that the data that you're collecting, the data that's being collected, it has the ability to be analyzed that way. So in addition to collecting whether the person is male or female, there are other things that we can embed in the initial data collection that can help us with the analysis later on. And it's worth thinking about those up front, because we did see a slew of studies that would have benefited from having a more in-depth sex and gender data collection, but by the time you get to the end of the study, it is of course too late. So so bringing the study design and the analysis plan would be amazing. And I think the goal there, I mean, this is a dream goal, but the goal there is that any research that is done through Katz would include a sex and gender analysis, and we can help create that. And I hope, Steph, that you'll agree that it's not only painless, but actually fun.
Yes, I can attest to
Yeah,
that. And also, not only from just a sex and gender, from a BIPOC
yeah.
perspective. So, we've been kind of pulling out some data about that. So, incredible. Where do you see this WIN registry going a year from now or 3 years from now? Because you've been in this space for so long in this translational research world. Where can it be in a year, like I said, and then a couple years from now? Where is it going to get us? Are we going to get to that? And I looked at the statistic for New York that you presented, top 10. We should be top 5. How do we
Yeah.
get there as a part 2 question?
Yeah, well, I think the question about the WIN registry is really one for this group. So the idea is that this isn't going to be necessarily just my research solely. That won't work. Much as I wish that there was enough of me, there isn't. This is about lifting up all of us in research that really matters. So I think our main goal there is to identify research that matters to us as Katz Institute, and to the people that we see in the communities we serve, and really creating or wrapping around rigorous research that helps us better understand and then deliver better care. Steph, you are, sorry, I don't, and not to put you on the spot, but you're an exact example of how that gets done. So you're working in menopause. We can educate people more about menopause. We can offer certificates in menopause. We can study our own menopause, and we can do investigator developed and industry sponsored if you wanted, but in my case, investigator developed studies that help us deliver the best possible care, and then write about it and talk about it and apply for grants about it, so that we can show our own, that we can show the work that's being done in a peer reviewed, rigorous way. So I think we're right. I say this all the time, and I really mean it. I feel like I got on a rocket ship that took off right after they closed the door. Like this, we are so well poised to do the work that we want to do, and to lift up the institution in the way that we want to do it. I feel like I'm mostly along for the ride, but I'm happy to also pedal. Like I will also pedal in the background to lift us off. But I think the way that you've constructed your work, and others on this call have constructed their work, Dr. Vinkoff and Nisha Parak, are all in that space of the care that we're, the intersection of the great care that we offer, the great reach that we have, and then leveraging that for research.
And so, how do we get to the top 5 for New York State?
Well, let's start there, and then we'll go. That's from the Commonwealth Fund. We can click on the side arrows, and they'll show you what goes into it. So that'll be our next meeting. As I invite me back, and we'll dig into the Commonwealth Fund and what goes into that.
And I would say, are there any parting words? Because the breadth of the membership for Katz is from early investigators to clinical team members across multiple disciplines. How should somebody who's even having an interest in research, and a lot of the work that can be done can be not just from these big trials, but
Yeah.
just to understand, how are we educating? Where's that information coming from a specific women's health related topic? How would you best encourage somebody to spark that interest, and how can Katz help partner with their desire and questions?
Yeah, I love that. I think we're still figuring out the best way to do that. I would say right now, and please correct me, Stephanie, if you would disagree, but we've had just one-on-one meetings with people, thinking about how they can construct research in their department for themselves. The WIN registry can help us all. That's actually the point of that. So we wanted to start, for example, in cardiac. Nisha Parat generously offered to start us off in cardiac OB. But if you wanted specific questions answered from your practice, right, from your area of specialization. What we're trying to do is build this WIN registry so that when we bring it to your area, you can add specific questions to it. We get at the national level, for all of us, we get people all the time who want to add a question, add a survey, add this, and if we can't, because nationally it's very hard to do, but locally, if we brought this to your practice, Steph, or Dr. Vinkov's practice, or other people on the phone, to the complementary medicine, I know Deb McElliott's here. If we brought the WIN registry, we could collect that data going forward through that system, and then be able to analyze it, contact people for additional studies, and use the data ourselves.
No, that's great. And I think, again, the cheat sheet of how to get people enrolled would be part of the take home.
Yep.
I do not see any other questions in the Q&A. If anybody else has a question, please put it in there before we conclude. Is there anything else that was a close-ended question. What else should we take as a message on our departing words as we close up today's beautiful lecture?
I would just say we're really excited to be here. I'm so honored and excited to be a part of Katz. I think we want to be the sung heroes, not the unsung heroes. So we want to get that national recognition, and I hope that I can help do that. And I'm inspired daily by the Katzes and the way that they've constructed this, and the way that you all have constructed this at Northwell, and the generosity and grace that comes with that. So just a real honor to be here, and I look forward to contributing to everyone's work.
Excellent. So everybody, thank you so much for joining. Do not forget to sign up for your CMEs, as we will send a link. We have 48 hours in which to do so. And for everybody, happy December. Have a beautiful holiday with your family. And we will see you at our next grand rounds. Thank you so much.